Good morning or good afternoon, depending on where in the country you are. My name is Chris Stilla, and welcome to a conversation on the effect of payment models in children's health care. This is the last in a series of several webinars that Lucile Packard Foundation for Children's Health has been sponsoring. I'll just introduce myself quickly. I'm a professor of pediatrics. I'm a general pediatrician at Children's Hospital Colorado. I do research and academic work in systems of care for children with special health care needs. Next slide, please. Today's discussion features one of the articles from the March 2018 of the Pediatric Supplement entitled Building Systems That Work for Children with Complex Healthcare Needs. The articles in the supplement feature writing from leading healthcare providers, family representatives, advocates, policymakers, and researchers. We hope the articles will help to clarify some of the difficult systemic issues and challenges affecting healthcare for these children and point the way toward their eventual resolution. As I mentioned, today's conversation is hosted by the Lucile Packard Foundation for Children's Health. You can access all of the articles in this series and our archived conversations of previous webinars for free by visiting the website lpfch.org/AAP supplement. Next slide. Most importantly, we hope you will all ask questions. There will be plenty of time at the end of the webinar for questions and answers with all of you and with our panelists. So please enter questions in the GoToWebinar question box, and we will field as many as we can. Please know that previous webinars have had many more questions than we could answer in the time frame, but that many of your questions will be answerable offline by the panelists after the discussion. This has worked well before, and we anticipate that it will work well now. A couple of housekeeping items. All attendees will be muted for the duration of the webinar, so you won't be able to talk, so please enter your questions in the question box. And a recording of the webinar and all the slides will be posted on the Foundation website and shared with all registrants via email. Again, the website is lpfch.org. I'll introduce our speakers today. I'm very excited to have three expert panelists for today's conversation. Our first speaker will be Dr. Carolyn Langer, who is Chief Medical Officer of Fallon Health in Massachusetts, and one of the lead articles of the article, Evolving Federal and State Healthcare Policy Toward a More Integrated and Comprehensive Care Delivery System for Children with Medical Complexity. Joining Dr. Langer today are also two great experts in the field. I'd like to welcome Joan Alker, Executive Director and Research Professor at the Center for Children and Families at Georgetown University, McCourt School of Public Policy. And also with us is Dr. Margaret Kierkegaard, a family physician and principal with Health Management Associates. So welcome to all of you, and we will start off the conversation with a few words from Carolyn. So Carolyn, take it away.
Great, thanks so much for the kind introduction, Chris. So you have my bio in the materials. One piece that wasn't in the bio is that I myself am the parent of a young adult with autism and intellectual developmental disabilities. So this subject is not only near and dear to my heart, but I truly both talk the talk and walk the walk, as many of you in the audience do. So next slide, please. So this is the agenda. I only have about 12 minutes to go through about the same number of slides. So I will probably go through these first set of slides quickly, some of the background material, so that I can really spend time focusing on alternative payment models and more specifically on accountable care organizations. Next slide, please. So I think it's worth taking a minute to talk about what we mean by children with special health needs and what I consider a cohort of this, cohort of this group, which is children with more complex needs. So we generally define children with special health needs as those children with special health care needs who have or are at increased risk for a chronic physical, developmental, behavioral, or emotional condition that requires health and related services of a type or amount beyond that required by children generally. And when we talk about children with special health needs, there are some important statistics to keep in mind. 20% of children in the U.S. have special health care needs, and about 23% of children with public insurance have special health care needs. Now, 17% of children with special health needs have typically 4 or more chronic conditions. When we think about that subcohort of children with more complex needs, it's important to note that 60% of children with special health needs have more complex needs, and roughly 2/3 of children with medical complexity are enrolled in Medicaid. And oftentimes, these children are eligible for Medicaid specifically due to their disability or condition. So in our state, for example, you can qualify for Medicaid as your primary insurance if you are below a certain poverty level. And for other children who don't meet those financial requirements, they can buy into our state Medicaid program if they have certain disabilities. Now, children with medical complexity account for 34% of Medicaid spending on children, and 40% of Medicaid spending for children with medical complexity is tied to hospital care. Only 2% is actually tied to primary care. And this will become important as we talk later about ACO models and how they're financed. Next slide, please. So it is important to remember that under the Medicaid program, there is very, very broad and comprehensive coverage, especially under the early and periodic screening, diagnostic, and treatment benefit, or EPSDT. This applies to children under 21 years of age in the Medicaid program. And this covers the early identification and treatment of health issues in children, including behavioral health and substance use disorders. It also provides all treatment services that children need and that Medicaid can cover, even when Medicaid does not specifically cover these services for adults. The litmus test is that benefits must be covered when they're necessary healthcare, diagnostic services, treatment, and other measures to correct or ameliorate defects in physical and mental illness and conditions discovered by the screening services. So it's a pretty broad array of services. Next slide, please. So despite the very broad and comprehensive package of benefits, there still are oftentimes access issues and unmet needs. In general, children do have good access to services in the Medicaid program. However, some children with special health care needs in particular face barriers and have unmet needs. In terms of barriers to access, 35% of families with a child with special health needs report having trouble accessing community-based services, and 22% of families had problems getting referrals to specialists. In terms of unmet needs, 19% of families with a child with special health needs reported at least one unmet need, for example, preventive care, specialist care, prescription medicines, and this number increased to 44% when the child was medically complex. Medicaid families also reported 32% more unmet needs compared to families with private insurance, and uninsured families reported 4 times the number of unmet needs. Next slide, please. So I think it's important to remember the role of the medical home. And I truly believe that the medical home forms the foundation for any sort of payment model. It really must be the linchpin. The medical home provides integrated care, and this is across primary care and subspecialty care practitioners, but also across medical, behavioral health, and long-term services and supports providers. A good medical home should also coordinate care across multiple provider types. So coordinating care across medical practices and institutions, schools, state agencies, and community-based organizations. A medical home also needs to take into account the patient's and family's needs and preferences, and it's really important, especially when you're talking about a Medicaid population, but all populations, to really provide culturally competent care. Next slide, please. So There is a lot of activity going on both within states and across the country in terms of payment reform. And every state is probably at a different level of payment reform. But what I will say is that probably just about every state has some form of payment reform occurring. Now, at its most basic level, some of the more fundamental models involve a fee-for-service model where clinicians and other providers are paid by the service. So they're paid for each encounter or the volume of work that they perform. In these types of models, there's limited integration. But as you move across this continuum, you see models where providers are taking on more risk, more financial risk, and more risk for managing populations. And you also see, as you progress along this continuum, a greater focus on fuller care integration across the care continuum. So some of the more basic models that are still in that fee-for-service domain might incorporate elements of pay for performance. Some models may pay add-on payments, medical home activity payments. And then as you progress down, these provider groups take on more risk. So it might be in the form of some sort of bundled payments shared between hospitals and physicians. It might be episodic bundling, so bundling for a particular condition. And then at the most integrated level, we start moving towards global payments or capitated payments where the provider groups take on a significant portion of the risk. Next slide, please. And just one more, if you could hit the one more time. So as I mentioned before, sometimes in these models there are add-on payments, and this could occur at all levels of the continuum where infrastructure payments might be included. They're often called different things. In different models, they might be a medical home activity payment. They might simply be called an infrastructure payment. But the idea behind these payments is to help the practices to develop the infrastructure to move towards this more integrated and coordinated model of care. And oftentimes, particularly as you move further down this continuum, there are often opportunities for shared savings with the providers that are taking on this risk when they demonstrate improved outcomes and lower costs. Next slide, please. So why is there so much interest in moving away from this fee-for-service world to these alternative payment models? Well, I think there's a strong case to move to some forms of alternative payment models. If you look at our current fee-for-service system, again, this is really a very unsustainable model where the focus is on payment for volume. The emphasis is often on emergency or acute episodic care. These systems provide significant complexity that is often difficult for the patients to navigate. And fee-for-service systems are often fragmented. They often lack coordination of care. Sometimes there are multiple doctors treating the same patient for the same condition without even talking to each other. Oftentimes there's limited data on quality and efficiency of care. And patient information is often stored in silos. Thankfully, we're moving away from paper medical records, but we still see some of that. I really do think that the horse has left the barn, and most states, as well as the federal government, is really moving towards alternative payment models. These are seen as being more sustainable. The idea behind alternative payment models is that rather than rewarding for volume, they reward providers for outcomes and value. The member's health is managed seamlessly across providers and over time, not just visit by visit. Providers engage in patient-centered care planning, and that also should include the patient. Providers act as a team to ensure coordination of the right services at the right place at the right time. There's Also greater transparency around quality and cost data, both for providers and for consumers. And these alternative payment models typically promote adoption of appropriate health, electronic health information, electronic medical records that can be readily available across the care teams and with consumers. Next slide, please. So there are a number of different types of alternative payment models, but I'm going to focus for the remainder of this talk on accountable care organizations. These are one of the more popular APMs that we are seeing emerging. So what is an ACO? An ACO is a group of doctors, hospitals, and other healthcare providers who come together voluntarily to give coordinated, high-quality care to the patients they serve. ACOs typically receive a risk-adjusted global budget to manage the total cost of care for a defined population. And many times, these global payments are often accompanied by both upside and sometimes downside risk-sharing arrangements and quality incentive payments as well. These ACOs promote coordinated care and improved population health management that helps ensure that patients, especially those with chronic illness or disability, get the right care at the right time, with the goal of improving communication across providers, promoting preventive health care, and avoiding unnecessary duplication of services and preventing medical errors. Next slide, please. So in Massachusetts, our state Medicaid program called Mass Health launched a new ACO initiative this past March. It includes 17 ACOs that partner with managed care organizations, and in addition to being responsible for the medical spend, the ACOs are also responsible for pharmacy. They're also financially at risk for behavioral health spend. While they're not yet at risk for many of the long-term services and supports, there is a requirement within our ACO initiative for each of the ACOs to partner with community-based organizations that we call community partners in order to really promote full integration with both the behavioral health and the long-term services and supports providers. So we have two types of community partners. We have behavioral health community partners and LTSS community partners. Again, these are community-based organizations that provide care coordination and support to help their assigned members navigate the complex systems of medical services, behavioral health services, long-term services supports, and social services. The goal is also to partner with these community-based organizations in order to reduce the fragmentation and the silos in the care delivery system that hinder care integration across behavioral health, LTSS, and physical health. They also create an opportunity for our ACOs to leverage the expertise of existing community-based organizations. The partnership with the community partners also strives to improve the member experience, the continuity and quality of care, to improve collaboration and delivery of integrated care. So in Massachusetts, our state Medicaid program has contracted with 27 different community partners across the state. 18 of those are specifically behavioral health community partners, and 9 are LTSS community partners. Next slide, please. So this is a very busy slide, but it shows how this model seeks to promote integrated patient-centered care. And I won't go through all of these, but you see here all the key players. So we have primary care providers, community-based providers, we have the behavioral health community partners, and the LTSS community partners. The community partners, and I think this slide demonstrates this very well, are really providing a key link from the clinical practices to the community. And not only do the community partners provide care coordination, but they also help to refer members to other community resources. They are especially attuned to cultural and linguistic needs of these patients, and have a particular expertise in delivering care and flexible services to individuals with behavioral health and LTSS needs. Next slide, please. So what are the specific responsibilities of the long-term services and support community partners? And I am focusing now on the LTSS community partners because those are the ones for children with medical complexity who would most often be involved. So the LTSS community partner provides care coordination and navigation for specific members, those between the ages of 3 and 65 with complex LTSS needs, such as children and adults with physical disabilities, developmental disabilities, and brain injury. Where members might have other state agency or provider supports, the community partners will coordinate with these supports and will supplement but not duplicate the functions provided by these other agencies. So, for example, our Department of Developmental Services, Department of Children and Families. The community partners will also find and engage members. They'll provide LTSS care planning, participate as part of the care team, including integrating with the clinical team, provide support for transitions of care, and connect members to social services and community resources. Next slide, please. So what are some of the challenges specifically for children with complex healthcare needs as we start thinking about how we design alternative payment models? So there are some fundamental assumptions and priorities that drive alternative payment models for adults that may differ from the needs of children. So, for example, there are a number of alternative payment models that use measures of quality of care for adults that often focus on common chronic diseases such as hypertension and diabetes. And sometimes the measures that are used in some of these alternative payment models are heavily weighted towards adults and common conditions among adults. So in designing these alternative payment models, it is really critical for the payer to be mindful of the needs of pediatric population, including those with complex healthcare needs. Another challenge we see, even when there is an intentional effort to design measures for the pediatric population, including those with medical complexity, there is a lot of heterogeneity of pediatric conditions. And oftentimes, as we're trying to develop measures, we'll often lack common measures of optimal outcomes, similar to those used in the adult chronic disease model, simply because there may not be enough children with any given condition to develop robust measures. And I'll talk more about this in the next slide. Also, the total medical expense for these alternative payment models, and therefore the opportunities for shared savings, is typically much higher in the adult population compared to the overall pediatric population. And that's simply because as adults age, they tend to be sicker and have more chronic conditions. And so the opportunities for cost savings are much higher in an adult population. Also, the systems supporting both adults and children differ significantly. Children, we think of children living in dependent family relationships and units, and they often have varied services, some that overlap with adult services, but some that are really unique to the pediatric population. So for children with complex healthcare needs, they often require significant coordination across diverse sectors and systems, such as coordination with the schools and social services, and sometimes the juvenile justice system. Next slide, please. So what are the implications as different states or other payers, including commercial payers, think about designing alternative payment models, and how can they be responsive to the needs of children with complex healthcare needs? Well, I would encourage anybody who is in a state that is thinking about rolling out ACOs or other alternative payment models to seek opportunities to provide either formal or informal input. And many payers, including both public payers and private payers, will actively seek input by stakeholders. In some instances, this is through the formal assembly of different advisory groups, and in other cases, it might be through formal requests for information, and in other instances, just through informal input. But I would encourage everybody to provide input. And I would say that many payers really will listen and take heart to what you have to say. Also, there are opportunities with these alternative payment models to significantly expand the medical home so that it can really take care of the needs of children with medical complexity. So many times these alternative payment models really promote the medical home model and emphasize promotion of care coordination and care management. A number of these models will also emphasize the integration of physical health, behavioral health, and long-term services and supports. There are often incentives for coordinating care with other providers and community-based organizations. And many times these alternative payment models will provide flexibility to meet the unique needs of special populations. So if a practice is receiving a global payment, they may have the flexibility to invest some of those funds in areas where they perceive the greatest need, depending on their patient mix. Alternative payment models can also assure the adoption of medical home elements through certification requirements. So in some states, some payers actually certify ACOs. NCQA has a medical home certification as well. Sometimes these medical home elements are promoted through contractual obligations. So payers may have specific contractual provisions with ACOs around certain types of infrastructure that are required to participate. So in other words, they may require a designated care coordinator in every primary care practice. And there may be other contractual obligations as well to support the medical home model. Many times, typically APMs will also incorporate quality measures that serve as measures of the adoption of medical home elements. Also, processes, I think this is a really important point to remember. Even though it is sometimes challenging to come up with specific measures around pediatric care, especially for children with complex healthcare needs, it is important to remember that certain processes that improve pediatric health may also improve adult care and vice versa. So quality measure slates, payers will often look to cross-cutting measures that apply across a broad swath of their patient population. An example of this is having a shared plan of care, and that is something that could be a measure that would apply both to pediatric populations, especially to children with complex healthcare needs, as well as to an adult population. And as I said at the outset of this slide, stakeholder input is really valued and really can be impactful. So again, I would encourage folks in the audience to really feel like their voice will be heard. So I just want to mention, for example, in the Mass Health ACO initiative, we have a little over 20 quality measures. And, you know, certainly there are some measures that are kind of the generic measures that you would expect to see in any quality measure slate, such as childhood immunization status, asthma medication control. But there are a significant number of measures related to behavioral health. So, for example, depression remission, follow-up after an emergency department visit for mental illness, follow-up after hospitalization for mental illness. And many of these are measures that apply both to the pediatric population as well as to the adult population. There are some measures, though, that are specific to pediatrics. So, for example, there's a measure around metabolic monitoring for children and adolescents on antipsychotics. But in addition to that, some of the measures that are particularly relevant to children with complex healthcare needs are measures around health-related social needs screening and long-term services that supports community partner engagement. So ensuring that children who are engaged by one of these long-term services and supports community partners receives a care plan within a specified period of time of being assigned to these community partners. And so that's, those are just some examples of how in an alternative payment model, much can be done to incorporate measures of interest to the population focused on children with complex healthcare needs. Next slide. So with that, I will turn it over to Joan.
Okay, thank you so much, Carolyn, and it's a pleasure to be with you all today. I'm going to start by just responding a little bit to what Carolyn said, building off of some of her points, and then take a step back and look at the context that Medicaid is operating in, both from a political perspective and a policy perspective, and what's the best way to how to promote better care integration for kids in the Medicaid program. So I think Carolyn did a great job laying out how important Medicaid is for kids, especially kids with complex medical conditions, and also that the statutory definition of the early periodic screening diagnosis and treatment benefit is quite a mouthful. EPSDT is really strong. And I think a lot of what all of us need to do in Medicaid, thinking about kids, is really to try to meet the promise of EPSDT in states across the country. Certainly there's wide variability, even though there is one federal definition. So just as an aside, we have started here a project with the American Academy of Pediatrics to produce more educational materials about EPSDT. Those are available on our website. But getting back to sort of the arc, I guess, of how services have been delivered to kids in Medicaid, looking back just very quickly over the last sort of 25 years since I've been working on Medicaid. In the mid-90s, we really saw a move to managed care for children in Medicaid, primarily those who are in because of their incomes, less so for kids who are in the child welfare system or kids with special needs. But today, I think we see really another wave of movement towards managed care, both in terms of the populations and more complex populations going into managed care, as well as the services. For example, behavioral health, which many states had carved out, in some cases is getting carved back in now. And these transitions to managed care have been more or less successful. States have not always done a great job with them. And I would certainly agree with Carolyn that stakeholder input is critical. It's also unfortunate, and I think Carolyn pointed this out, that oftentimes there isn't much focus on children, even though children are everywhere the largest single group in the Medicaid program, but because they don't cost as much, there isn't so much of a focus in policy making. But of course, Medicaid is critical for children writ large, and especially those with complex medical conditions. So I just want to diverge for a second and just say the context that we find ourselves in, and this is discussed in the article, we have seen enormous progress in getting kids' uninsured rate down, which has been really a great success story for our country. I think it's an underreported story, but unfortunately, we are now going backwards. We have a report coming out on November 29th, so I'm not going to go through all of our findings there, but just to say I've been writing this report for about 8 years in a row now since this data source became available. And this is the first year that we are seeing a statistically significant increase in the number of uninsured children. That was not true for the population at large, but when you pull out children, it is. And there are ways these kids are clustering, particularly in states that have not expanded Medicaid, states with large American Indian populations, other things that we'll be sharing in our report. So just want to highlight that because I worry that we're seeing a divergence among states, quite a radical divergence. So stay tuned for that. And I do, just to say one more bad news note on that, the trends that we think are causing this loss of coverage we expect to worsen in 2018 when we get the data next fall. Trends such as the undermining of the marketplace, the increasing intimidation of immigrant families, and now the public charge guidance. We fear this trend will get worse next year. So it's really important for all of us thinking about kids' health to understand that coverage is critical, and we cannot take for granted that our progress in reducing the number of uninsured kids will continue. Having said that, it's a really fascinating time to be working on Medicaid, which I have been working on, as I said, for about 25 years. I think one of the lessons I took away from last night is that Medicaid has never been stronger. The Medicaid expansion passed on the ballot in 3 very red states, and Medicaid, I think, was a critical issue when the ACA repeal failed. And in fact, children with special needs became a very visible population in that debate. And so, of course, given that the House flipped, that's good news for Medicaid. We wouldn't expect to see an effort to cap and cut the program severely as the ACA repeal did. But we can't assume that Medicaid is out of the woods because of the growing deficit that has really been caused by the passage of the tax bill. There will be enormous pressure on Medicaid because of the aging population, because Medicaid is weaker politically than Medicare and Social Security. This is going to be an ongoing issue and something that we all have to remain vigilant about. And it's amazing, as I said, I think Medicaid is sort of the best of times and not the worst of times by any means, but really Medicaid, I think, has become so much more visible in the last couple of years and really has a lot of public support, which is exciting. So let me just conclude, because I know we're a little short on time, with talking about what is the best way to promote better care integration. I think Carolyn laid out many, great ideas that we would absolutely agree with, for example, prioritizing a family-centered medical home, et cetera, et cetera. But I don't think legislative activity at the federal level is the way to go, certainly not in the near future. And I'll just leave it at that. We can talk more about that in the Q&A if folks want to dive into that. It's actually very hard to make changes to Medicaid through the legislative process, which was the good news last year when the ACA repeal failed. And typically states, they already have a lot of room, a lot of flexibility in their Medicaid program to make changes, particularly in the area of delivery system reform. And then there's always the option of getting a Section 1115 waiver. And that's how, frankly, a lot of policy change gets made in the Medicaid program. We see right now the Trump administration using 1115 waivers to promote what so far has really been their signature Medicaid initiative, which has been to impose work requirements, reporting requirements on folks in a number of states. But, there are waivers that move things in a positive direction. Even the last couple of weeks, the state of North Carolina received waiver approval for their move to managed care, which I have not yet had a chance to read it, but I understand has a lot of really positive changes to it. And there was a lot of concern in North Carolina about moving to managed care because they actually had a great Medicaid program for many years. And I think the state there took very seriously thinking about how to improve care as they were going there. So there's a lot of interesting specific performance improvement projects the state is contemplating, some funding, looking at social determinants of health, So that's exciting. And on the flip side, we have the state of Iowa, which did a very poor job of moving to managed care, particularly for kids with special needs. So to me, the state level is where to direct your input and activity, and also to not assume that this administration won't grant a good waiver, such as they just did in North Carolina. So with that, I think I'm going to hand it over to Margaret.
Great. Thank you so much for those comments, Joan and Carolyn. It's been a great introduction to what we're talking about today. I, too, am going to keep my comments relatively brief because I think the heart of this conversation is really in our question and answers. And my first comment here echoes what Joan has already said, that the proposed changes to Medicaid over the past 2 years really represent a serious threat to children's health care in terms of the block granting and decreased funding. And I also put adult work requirements in that bucket. We know that in families, if the parents are uninsured, then children are much less likely to be insured. And so creating hurdles for any family member to insurance may impact the children's access to health insurance, even if they are eligible. Turning our attention now specifically to how alternative payment models are operationalized in Medicaid, I think it's important to remember that providers overall are generally more anxious about APMs in Medicaid populations than they are in other populations, for example, Medicare or the private insurance. And some of these factors were discussed by Carolyn in her slides, so I won't reiterate those. The biggest factor on the children's healthcare side is that there's not an immediate obvious savings in children with special healthcare needs. It's not like the chronic disease adult patients where there's immediate savings by doing better management as an outpatient and therefore reducing hospital stays and emergency stays. And then to think about that more in the Medicaid arena, most providers feel that Medicaid is underfunded to begin with. So we know that Medicare payments for providers range anywhere from 60% up to 100% of Medicare in a very few states like North Dakota or Alaska. But by and large, payment for Medicaid is less than Medicare. So when you're talking about a shared savings model that is already underfunded, it's hard for providers to feel confident that there's actually going to be savings to share. Additionally, there are all the social needs that need to be addressed for a Medicaid population that providers are less comfortable accepting risk for. So for no-shows and patient adherence, low health literacy, all of those issues that make it more difficult to manage that population. We also know that Medicaid population is transient in terms of their health insurance status. They may be eligible for Medicaid and then they're eligible for an exchange product, or maybe they're not eligible anymore, or they fail to process their redetermination for Medicaid. And we know that clinical outcomes and APMs have some of their success on the continuity of care and the length of time a patient is enrolled in that particular model. So almost all of them show that the longer you have to work with a patient over time, the more savings you can accrue. But if you have this high transient flux in and out from Medicaid, you might not have that opportunity. And then also thinking about providers and risk, we know that clinically, it makes better sense to aggregate patients with special needs together in a center of excellence. So to be able to deliver premier systems of care and reduce errors. But when you're talking about risk, you actually want to spread the risk over a population. So there's an inherent tension in that respect. As Joan mentioned, we're really moving to Medicaid managed care in the United States. So as Medicaid is expanding, Medicaid managed care is also booming. In 2000, we had 44 million people enrolled in Medicaid managed care, and now we're up to 72 million people enrolled in Medicaid managed care. So it's just been a tremendous expansion. And that really introduces the multi-payer complexity to APMs. Remember, APMs were developed largely in the Medicare arena, which is a single payer arena. So when you have APMs with multi-payer, that in and of itself creates complexity. And then thinking about the role of Medicaid managed care plans and how they're going to operationalize delegated care management and how they're going to supervise that at the level of the provider is still evolving. In addition to expansion of Medicaid managed care just in sheer numbers, we also are looking at these new populations coming into Medicaid managed care, such as children in foster care or the children enrolled in Katie Beckett waivers. So it's just created this whole new arena for both providers and Medicaid managed care plans who have not developed these systems and strategies. And then concomitantly, the oversight role for states and federal CMS is also evolving in regards to Medicaid managed care. We had a large rules for Medicaid managed care were released in 2016. It was the largest update about Medicaid managed care in over a decade. Those rules were released by CMS. And we know that the Trump administration has gone back to the drawing board with those rules, and we anticipate that they will be released again, a revised set of rules for Medicaid managed care sometime very soon here. And so that will have an impact on the oversight roles for states and federal CMS in regards to Medicaid managed care. But we know that the tools that are traditionally used by states, such as withholds or bonus payments based on core measures, don't really reflect well care for special needs children. So, and other things like a consumer scorecard might give consumers information on the percentage of children who get immunizations or who get dental visits, but they really aren't granular enough to help a family with children with special healthcare needs to really select the most appropriate or the best Medicaid managed care plan. And on top of that, there may be network issues. So if you're a parent and of a special needs child, you may have your behavioral health specialist may contract with one Medicaid managed care plan, your primary care doctor may contract with another, and your specialist may contract with another, and you might have to choose among those various networks. So I think it's really introduced a layer of complexity that we haven't completely teased out yet. I want to close my formal comments by directing another quote from Hubert Humphrey. I'm originally from Minnesota, so I have a soft spot in my heart for Hubert Humphrey, who used to be referred to in Minnesota as the Big H. And the article that we were all asked to read to prepare for this starts with a quote from Hubert Humphrey talking about how we take care of our most vulnerable populations and the role of government. And there's also another quote that's attributed to Hubert Humphrey, which is that your concession speech is the first speech of your next campaign. And I'm not making that comment because we just finished an election. I'm making that comment because there's a spirit of never giving up. And I think in terms of advocacy for this population, for children with medical complexity or special healthcare needs, that spirit of never giving up, of continued advocacy needs to animate everything that we do. So with that, I'm going to turn it back over to Chris to moderate our conversation around questions and answers. Thank you very much.
Great. Thanks very much, Margaret. And thank you to Carolyn and Joan as well for some really great points. I think it's very clear that the work is only beginning, especially with children's health and especially with children with complex medical needs. So we've got our work cut out for us. We, not surprisingly, have received a lot of great questions. We won't be able to answer all of them, but several may be answerable by the panelists offline afterward. I'm going to begin with just a couple of kind of quick housekeeping questions to orient us. Patricia Williamson asked, how many states are currently using ACOs? Do any of the three of you know more or less what that number is?
I do not.
This is Margaret. I don't either. I think it's very few that are really using ACOs and pediatric Medicaid.
That was my impression as well. It's certainly not ones that actually work as the full, ACO concept of getting everyone to work together in a team. I think that's the biggest thing that we need to work on, honestly. Okay. And then,
sorry, this is Carolyn. I don't know the exact number. One organization that might be a resource would be the National Association of Medicaid Directors, and they may keep some data on that.
That would be great, especially for ACOs that include kids. Another quick one is, I think many of us are interested in when Jones and Jones Group's report will come out on trends in uninsurance. And it would be great if you could share any information about where to find it and when it will come out.
Yes, it is coming out on November 29th. And it will be available on our website, which is ccf.georgetown.edu. We do work with state children's groups around the country, so a lot of them tend to co-release this with us and talk about what's exactly going on in their state. So hopefully, there'll be a lot of ways that folks can hear about this and think about what it means for where they live. I would also mention we have a very active blog, the Say Ah blog, and we keep track of all kinds of things, waivers, coverage levels, quality measures. I did want to mention that the latest extension of the CHIP program does mandate reporting for states, not for some years till 2024, of the child core set. So there's a lot going on, and please, check out our materials and resources.
Great, thanks, Joan. The next question is from Jerry Lamb. Jerry asks, while there are compelling arguments for alternative payment models, how well are they working in practice for parents of children with complex care needs? Are we beginning to see promising differences? And then I would add, if we are, which states should we look to for best practices in APMs?
So, Chris, this is Carolyn Langer, and we just launched our ACO initiative in March, so we don't yet have any long-term outcomes. But I'll give you a great anecdote, and I realize this is just one case. We had a member, a child who's actually a tween, and we all know how tweens want to fit in with their peers, newly diagnosed with diabetes. His mother was estranged from the family because she suffered from substance use disorder. So he was dealing with all these issues, and he was assigned to one of our ACOs. And, just to show how they took a comprehensive view of this child, yes, certainly they immediately focused on his medical issues, but they also had their case manager address a lot of the psychosocial issues. And this case manager identified a special summer camp for kids with diabetes in New England. This was a very low-income family. He didn't have the money to attend the camp, so the primary care practice, the medical home, was able to negotiate a scholarship, a full scholarship. But on top of that, they took up a collection and helped to put together all the supplies and sleeping bags and flashlights that this kid needed to bring on his packing list. And he came back really a new individual who not only was happier, but also had much better insight into both his clinical condition and his family situation. And I realize, again, that's only one anecdote, but I think you do highlight an important point, which is we not only have to think about patient outcomes, but also how do these alternative payment models really improve the health and well-being of the entire family unit.
Great, thanks, Carolyn. Others' perspectives?
This is Margaret Kierkegaard. I would definitely agree with that. These patient-centered and family-centered outcomes, I think, are critically important for us to think about as we build ACOs, that rates of the typical ACO measures, like rates of hemoglobin A1C, are just not applicable. And I would say that by and large, we have a lot of scattered experimentation with Medicaid ACOs, for example, in Colorado and Minnesota, and scattered experimentation with the health home model, which is a little bit like, it's the Medicaid 2703 health homes, which has created care management structures for children with special needs, but they haven't evolved to the point of, by and large, APMs yet. So I think we're very much in the embryonic developmental stages of Medicaid ACOs in the pediatric population.
This is Joan. I just wanted to actually jump in and amplify an earlier point that Carolyn made, which is that none of these payment models and attempts to improve delivery systems are going to work if kids are falling on and off the program. So we talked already about more kids becoming uninsured, but another policy that's really important is 12-month continuous eligibility, so that kids are continuously covered. They don't fall off due to redetermination or paperwork barriers, and not all states have that. In fact, I think the majority of them don't. Some of them have it for CHIP and not Medicaid. So that's a really important policy piece, because if you don't have that, you cannot even you can't measure quality, you can't track these outcomes. So just wanted to throw that out there.
Great. And I'll just add my 2 cents as a clinician and a clinical leader, and I talk to clinicians in other states. I think that the key things have already been touched on, but just to reiterate, the incentives and the measures need to make sense for children with complex needs. The incentives need to be big enough to enable practices to implement strategies such as care coordination for children with special healthcare needs. One example might be to hire a care coordinator or a piece of a care coordinator that can help with that. And then families can begin to see the difference. It's pretty hard if families can't see an enhancement of direct services based on whatever incentives the APMs have. Great. We have time for one more really quick question. I think probably the best, and I am going to try and condense this a little bit because it requires too much time, but are there any specific, Abigail Barth asked just a couple minutes ago, are there any specific resources you can point families to help guide their search for the best plans for their children with complex healthcare needs?
That's a really great question. And there's unfortunately not a great way to do that. We actually have a paper that one of my colleagues wrote about how do we know if Medicaid managed care is doing a good job. So you can check that out on our website as well. Unfortunately, the answer is that oftentimes we can't tell. But anyway, that could be a good follow-up resource to start.
Great. I'll just put in a plug for the family-to-family health information centers that's run more or less by Family Voices. All 50 states have a family-to-family health information center, and they're staffed by parents of children with complex needs, and they would be a good starting point for any of you.
Chris, this is Carolyn. I just want to highlight that to the extent that families might have choices, particularly for children with medical complexity, they oftentimes have long-standing relationships with specific types of specialists. One of the most critical factors is to make sure that those specialists or primary care provider or other therapists are in the network of any health plan that they select. So it's good to do that homework up front before signing up for a specific health plan.
Great, thanks. Unfortunately, we're at the top of the hour, and we will try and answer the remaining questions offline. But thank you to all of you. We had over 200 attendees on the call today. Thanks for attending today's conversation. A recording of this conversation and slides will be sent to all attendees and posted on the Foundation website. This, unfortunately, also concludes our series of conversations, though they've been great, on the pediatric supplement for building systems that work for children with complex health needs. We hope you all found them informative, and you can access them all at lpfch.org/AAP supplement. Please be sure to complete the survey that pops up at the end of the session. This gives us valuable feedback on this series and will inform future webinar series. So thanks again to all three of our presenters. Thanks to Amanda Lanzaplain for doing such an excellent job in organizing the logistics, and to the Foundation for sponsoring it. Have a great afternoon.